Hello, good afternoon, and welcome to this new SPHR Network webinar, HERICOM webinar series on health and risk communication for public health. I am Dr. Marco Bardos. I'm the host of this webinar series, and it's my pleasure to welcome you today to a new webinar from Comfort Sanuade, is our colleague from Concordia University. Comfort is an experienced physiotherapist and early career researcher whose work is grounded in evidence-informed approaches to behavior change and health support. She has a strong commitment to individualized care. Comfort believes that there is always hope and pathway forward for everyone, no matter where they are or on their journey. Every intervention is salvageable to improve efficacy. This philosophy continues to shape both her clinical practice and her academic research. She's currently pursuing a doctoral study at Concordia University within the Montreal Behavioral Medicine Center. And Comfort's research focuses on refining and probably redefining the conceptualization, definition, and measurement of eHealth literacy or digital health literacy. Her research reflects a broader interest in understanding how individuals engage with digital health tools and how these systems can be designed to better support sustained behavior change. And this is why we are here today. So we're looking forward to hearing from you and understanding what your research has demonstrated so far. And I'm biased, I have to say, because I'm partly involved in this research. So I know something about it, but I think it's worth sharing with the rest of the network. So without much further ado, I let the floor to Comfort. And you can share your screen and slides. And
thank you, Dr.
the floor is
Burgess.
yours. You're welcome.
Thank you so much. Just a minute. All right, let me share my screen now. Hi, everyone. Good morning or good afternoon over there. It's morning here in Montreal. Morning, it's sunny and pretty hot. It's currently 27. So it's a sunny and hot morning. So good morning again. I am Comfort. I hope you can see my screen now. Yes, okay, thank you. So I'm Comfort, and I would like to actually thank Dr. Bartis for inviting me to present some of the work we have been developing over the past few years. And interestingly, this work began at the University of Birmingham. It was my academic home for like 3 months, and during that time, I had a lot of a few engaging discussions with Dr. Bardos about how to deconstruct and reconnect the different dimensions of eHealth literacy. And so I'm excited to then share some of these outcomes of the ongoing work today. And to add to it, my supervisor, who is Dr. Simon Bacon here in Concordia University in Montreal, he completed his PhD in Birmingham in the late 90s and early 2000s. So it feels very, very meaningful to continue that connection here today. So what am I doing? I'm presenting the early version of our final work on reconceptualizing and redefining eHealth literacy in an increasingly connected digital world. The focus is to answer a very simple and important question, which is how do we conceptualize eHealth literacy to reflect the way digital health actually works today and prepare our minds for the future systems that we have. And so I would continue. Before I continue, I would like to acknowledge that Concordia University and the CU's NIM, which are the locations of my research lab, the research lab of Dr. Simon Bacon, where this research is being done, and my academic institutions, they are both located on the traditional indigenous territories and the unceded territories of Kanya-Geaga Nation. And Jajoge, commonly known as Montreal, is historically known as a gathering place for many First Nations. So I express my gratitude to these indigenous communities who continue to steward these lands and provide a space for us to work, to live, and to play. So I continue. So digital health technologies, they promise to improve health management, support collaborations between healthcare providers and patients to better help people in their self-management journey and empower patients for greater patient participation in healthcare decision making. But what happens when we give people access to digital health tools without their ability to meaningfully navigate them? It's like giving someone a map for them to go to a particular destination, but they don't have the capacity, or you're not sure if they have the capacity to interpret or correctly look at the map and interpret how they're supposed to navigate their way, and also deal with bumps on the road. So that question is what brought us to e-health literacy. So healthcare today is increasingly being mediated by digital technologies. We now manage our health through apps, telehealth, wearables, and we have AI-enabled systems being added to our healthcare. And so these technologies, they do support more patient-centeredness, and they support the management of health outside the traditional clinical settings. And this shift was accelerated during the COVID-19 pandemic. We all know how we all turned to digital technologies. And so what we have now is that digital technologies are no longer passive tools. They are not just feeding us information, they actively shape our health decisions and our behaviors. Many people have a smartwatch. You would see when your smartwatch tells you, or you're looking at the number of steps you have, you're like, oh, okay, I only have 1,000, or I have less than 1,000 for today. So you're looking for a way to walk more or move around more, or oh, yeah, I only slept for 4 hours today, and you're trying to look for a way to reset. This is what is embedded into our everyday life, and so digital health again is no longer passive. So today, people are expected not only to access information, but also to interpret the dashboards that we have in different platforms, to respond to automated feedback, to navigate an environment that is shaped by algorithms. So modern healthcare digital systems are interactive, they are interconnected, they are constantly evolving. So as a result, individuals must now simultaneously evaluate the credibility of what they get, to interpret the recommendations that they receive, to manage digital interactions, and to still make health related decisions in real time across multiple platforms. And so this shift fundamentally changes what it means to be digital health literate. Even to the point of translation tools are now automated. Like you often don't need an interpreter to come to translate from English to your local language. It's done automatically. So everything is accessible in real time, and we have to make health decisions in real time. And um, so e-health literacy does then matter, because e-health literacy influences how people engage with these tools. It affects how people, it affects health behaviors, treatment adherence, the evaluation and participation in digital healthcare systems. And at the beginning, the first definition we had in 2006, you know, gave us a very big and a very important idea of what it's all about. The evaluation, ability to access, to find, to interpret, to understand and evaluate health information for healthcare, right? But that foundational definition came in at a time when what we had was Web 1.20. It was static information, it was passive, there was limited interaction. All you needed to do was search for what you wanted, and you get the response back, and that's all. But we've transitioned from that static information into more tools being added to healthcare. We have more access, we have more data, and all of these brings us the new challenges of misinformation. And now with the new AI-enabled systems that we have now, chatbots, personalized care, and all, it predisposes us to issues around privacy, trust, disinformation, the we having to adapt to all of these changes happening in the digital healthcare system. So the digital world evolved. It's not only that digital health has evolved, it's also that understanding of literacy. Now, this is not eHealth literacy, but literacy itself has changed. Health literacy in current research is no longer viewed simply as an individual functional skill or an individual cognitive skill. It's increasingly been understood as an interaction between people, systems, and environment in which the health decisions occur. But this conceptualization of e-health literacy, even though every other thing evolved, the conceptualization of e-health literacy have not evolved at the same pace at which digital health itself is evolving. So because e-health literacy, even though it was so focused on the literacies, your computer literacy, your scientific literacy, and all the other 6 core literacies that Norman and Skin and the original designers of the conceptualization of e-health literacy, what they brought to us, we now know that e-health literacy is now shaped by trust, by culture, by your motivation, by the design of the system. So different researchers have tried to then improve these definitions. And as these definitions evolved, they all evolved in different directions. And that created a fragmented understanding of e-health literacy, because some definitions focused on technical skills, some focused on information processing, some focused on trust, some focused on context, AI. And that created disconnected puzzle pieces. So this inconsistency creates problems for measurement, because if 3 different papers understand or are viewing e-health literacy from 3 different lenses, the result of those research cannot be compared, because everyone is using different lenses to look at it. And so it then affects intervention design, and that translates to an issue with policy development. So all of this became the motivation for the study, which was, can we just develop a consensus-based updated definition of e-health literacy that will reflect the realities of today's digital health landscape? And so what we did was an international Delphi study, which involved bringing in all these experts. Everyone has different lenses, but can we bring everything together and look through everything and build something that every researcher would agree to, and this lens would be through which we then conduct our researches from. So it involved researchers, clinicians, digital health experts, and end users. These experts were from multiple disciplines, and they participated across different iterative rounds of rating and feedback. They gave feedbacks to establish the consensus on the essential components of what e-health literacy is. And we defined consensus at least 75% agreement based on pre-existing literature on Delphi. And so we then held a consensus meeting online, because again, we had different people from different countries and different regions. So we had 2 meetings online where the selected panel members, those who were interested, they reviewed the final result from the Delphi rounds, discussed on it, and voted on the inclusion on which items to include, and then the final wording of the definition of each of those items. So just to give you an idea of what the rating looked like for the 3 rounds, the participants rated each item according to its importance for understanding e-health literacy in the current and the future digital age. So they rated it from low to high. So low being that it is helpful but not essential, And medium means that item is a desirable one, and then high means it's an essential item when it comes to understanding and defining your literacy. So these were the initial eDelphi items that we had. So we had done an earlier scoping review to look through all the definitions that were existing in literature. Then we sort of broke down what we saw as the common themes and domains, features in each of those definitions. Then we grouped them into themes and sub-themes. So we had, at the initial stage, we had 7 themes, and 3 of them had sub-themes. So we had knowledge of specific health problem, and health experience with health information were the subdomains. And then we had skill. We had all those 5 skills attached to the domain of skill, and then context, systems, personal and environmental context being the subdomains for context. Then we have perceived competence, purpose, information seeking, and then scanning behavior. So then across those 3 rounds, we had 27 consistent participants from 10 countries and 5 regions. So mostly from North America. Then we had Europe, we had South America, Australia, and Asia. We had people from behavioral science, public health, health communication, and computer science. The majority were behavioral science and public health experts. And for the others, we had people in health literacy and end users. We had 2 end users join us to add their thought on what health literacy should be. And there was a self-rating of an average of 8/10. So they had to rate their knowledge of health literacy, their expertise, and the eligibility criteria was rating of 7 and above. So we had an average of 8, and for the sex, we had mostly female and mostly middle-aged group of experts. So we collectively we had a very diverse group of people, group of experts, and their expertise and they had a very high expertise in digital health and e-health literacy research, and that strengthened the robustness of the consensus process. So yeah, this is a visual of how it all went. We started with 17 items, which is 7 domains and 10 subdomains. From the first round, 2 items got excluded and 1 item got added. And by the time we got to the second round, there was the voting of whether we should still leave the 2 items that were excluded, and everyone agreed to it. And we had 15 items that were included and 1 item excluded. Then by the time we got to the third round, we had 4 items that were included, 6 close to cutoff, and 5 items that were excluded. And the 1 item from round 1 remained excluded. No one wanted to put it back into the list of items. So at the end of round 3, these were the items we had. The top row showed us the ones that were included. So we had knowledge and skill domain, and under knowledge, we had health knowledge being essential and critical thinking skill being essential when it comes to the conceptualization of the idea of skills. And context, the second row were items that were close to cutoff. And during the consensus meeting, we had to look at it one by one to determine whether we needed to include or not. And we had lots of discussion on how each of those items were defined and how it could be improved to better understand what they mean, which then translates to what e-health literacy means. And then at the lower level, we had the ones that were excluded, but we still went through them. And we had 2 consensus meetings because of different time zones. And it was very interesting. And at the end of the meetings, we had 3 core domains that were included. Despite the differences in all the terminologies and understanding that we see in research, the expert consistently focused on 3 interconnected domains: knowledge, skills, and context. And knowledge being an understanding of the health information, the health problem, and the digital system that is being used. Then skills being the cognitive, the technical, the critical thinking, and the application skills. And then context, talking about the influence of your language, the culture, the resources, the environment, and the existing political systems that is available. And there was that consensus of eHealth literacy being conceptualized as an interaction between the user's capability and the digital system demands. So I'm going to look at each of those domains one by one. So the knowledge domain included, again, the health knowledge and understanding of the digital environment. And the expert recognized that knowledge extends beyond formal education. It includes the experiential, contextual, and sociocultural understanding. So we had, like, the image I put there talks about the 2 types of knowledge. Like, and I gave examples of knowing what diabetes is, understanding how an app works. So knowledge of health knowledge, and then understanding of digital environments, digital ecosystem. And then we add the tacit knowledge, being knowing what information is trustworthy based on your past experiences. And also, this knowledge is gained through lived experiences, intuition, cultural background, and understanding of community. So, and that builds the body of knowledge the individual has. Then we have skills. This is the second very core domain, and it also received 100% agreement. Like 100% of the participants at the end of the consensus meeting agreed that skills domain should be included. And we're talking about the skills, we're talking about cognitive, critical thinking, technical, and application skills. And cognitive is the mental processes that leads to knowledge. So it includes memory, your attention, comprehension, and how you integrate new information into existing knowledge that the person has. And it also includes making a judgment on when you need to quickly um, scan a website or a page or an information, or when you need to dig deeper and make some analysis to make judgment for health. So that's cognitive skill. And critical thinking skill focus on how we process the knowledge now. Um, and it extends beyond just filtering trustworthy information from unreliable content, but it also goes into the ability of the person to evaluate the source of information, form judgment, question the assumptions, and then integrate that knowledge into informed health decisions. So that's critical thinking. And then we had the technical skill that includes the basic operational skills like using a mouse, using a laptop, and but then it also extends into the more advanced technical skills like being able to access generative AI tools or the metadata of a digital tool and all, or an information, and access that credibility using the metadata. So that's technical skill. And then we have the health application skill that reflects the capacity to move from not just information acquisition to real world application. And so we're talking about how whatever it is you're doing, information you have aligns with personal goals, clinical guidance, and contextual circumstances. So that's health application skill. And so this means that the necessary skill is not only about being able to use a device or open an app, it also involves knowing how to search for the relevant health information, scan it, navigate digital platforms, moving from one platform to another platform or synthesizing them together. You would we have situations where there's telehealth. You need to see an healthcare provider, and while trying to log in to join the meeting, you're asked to download another software to install and integrate the add-on. So those things require skills, technical skills, for example, and then evaluating the credibility of things that you are hearing or seeing, or the algorithms that are bringing to you, and then applying that information to real life health decisions. So participants highlighted that. So interacting with digital health technologies across different languages and translation tools is also part of the skills that is necessary. And it's very important now that we have a diverse community. The world is global and interconnected now. So language can affect how people understand um, information and the confidence through which the tools are being used. So, and then the third one is context. So, the experts recognize that health literacy does not occur in isolation. This is the part that hasn't been really emphasized on in literature, the place of context being a component of health literacy. So um, we we agreed that health literacy is part of it is shaped by a range of personal, social, technological, and system level factors. And at the personal level, we have the person's health status. If a person is diabetic, is likely going to be very much knowledgeable about diabetes, right? And have specific skills to navigate the journey of diabetes compared to someone who does not have that. So personal circumstances, the motivation an individual has, beliefs, the language, the emotional state of individuals on and how they influence the way they engage with digital health information. Same as the social environmental realities, talking about their education, income, housing, social support that affects access to health care. And then we had the technological factors, the kind of device, the internet connectivity, the platform usability, is it popping up a lot of ads that makes it frustrating? And so you just give up on whatever behavior change interventions that you were trying to um, access, things like that. And how it shapes the way people integrate and synthesize digital health information. Then we have the policy and system environment. So talking about data privacy, the internet regulation, the health policies, and how these things shape trust, access, and how those informations are interpreted. So an individual in an environment where government and healthcare system is trusted would relate and interpret the information they receive differently from someone who do not trust their government or their healthcare system. So it does make us know that overall this particular domain reinforces the fact that health literacy is not simply an individual's capability. It's deeply influenced by the environment, the systems within which the people interact with digital technologies. So, interestingly, not every concept reached the consensus. The experts generally viewed these as they were important, but they were not necessarily essential for understanding health literacy um, in current digital age or for the future, or they were embedded in those three domains already. So things like purpose was already in health application skill, perceived competence was already in context, and experience with online information was already in the knowledge part, and same with context. While context was seen as very critical and very important, the idea of bringing each of the domains distinctively, like being distinct, picking them as standalone item was something that the expert felt, okay, we didn't need to do that in the definition, and then social skill is an item that kept occurring as that's one of the departments kept saying, "No, we need this," but then by the time we do a vote or the rating, he ended up each round he ends up being rated as low. And part of the discussion is that we had with experts was them saying that, yeah, it felt like it was not just because social skill was talking about more of the interaction with people, communication skill and all, but the expert felt that it was not the communication itself that shaped e-health literacy, but rather the broader interactions surrounding digital health engagement. So these interaction elements were ultimately already considered in context, for example, or technical skill, for example. So um, the the consensus ended up being that no, it's something that shouldn't be embedded in it because it's in every other core domain that we have included already. Because it's not just communication that shapes the health literacy, it's that interaction and the other domains explained it better or captured that more than social skills. So um, this finding, I like the ongoing complexity that we still have in defining it. So overall, our findings suggest that EL literacy is not simply an individual trait. Rather, it reflects the fit between the individual capabilities and the demands of digital health systems. And successful digital health engagement occurs when the technologies, the systems, and the environment align with people's knowledge, their skills, and their context. So I'm going to give an example of just paint a scenario, which is like, okay, let's say a middle-aged or a 42-year-old office worker that knows about the ACSM physical activity guidelines, and he wants to improve his physical activity level. So he has limited time, is stressed out with caregiving responsibility, but he has access to digital health tools. So such a person, using the conceptualization that we have, if he has a high health literacy, so talking about knowledge, he understands the guidelines. He knows that short um, exercises still count. Even though the recommendation may be 30 or 20 minutes of moderate intensity 4 times in a week, he knows that he can do 10 minutes of high intensity exercises and do it for a shorter period. He understands not all online fitness advice is credible, right? So he's able to filter through the things that his algorithms bring to him. He's able to even search beyond what the algorithms bring to him. He's not just looking at the top 10 or the top two results that he gets when he does his search. He's looking through everything, looking through different perspectives. So that's knowledge for him. And skills is, sorry, just a minute. I moved too much. Okay. Yeah. Skills being that um, he uses the apps, uses the wearables effectively. He evaluates his trustworthiness. It's not just depending on it blindly. He adapts his exercises to his daily routine. He uses quick workouts realistically, and then context being that he works around these time limitations that he has, the available digital tools that he has, and adjusts the goals to fit his real life situation. So he he can increase the timing and maintain the intensity, or reduce the timing, maintain, or the type of exercise they will do, resistance instead of aerobics, based on the season of life he's in. So it produces meaningful and sustained engagement with physical activity. Now, whereas if it's somebody with low health literacy, he knows that exercise is important, right? and he believes that exercise must be intense and time consuming, and believes that it has to follow the ACSM guidelines to the letter, you know, and then it gets a lot of apps, different wearables, and is going through them, and all of them are giving different recommendations. So he's overwhelmed by conflicting online advice. He cannot evaluate the effectiveness or credibility of each app recommendation, struggles to apply the information realistically, and then talking about his context, time pressure becomes a major barrier for such a person. So when they're in a situation where they have limited time, no exercise all through those periods, and there is low confidence because now the behavior, the physical activity behavior they were trying to improve becomes inconsistent, and then they disengage. So, under this conceptualization, a person with high health literacy is not necessarily someone who exercises perfectly or uses every digital tool successfully. Rather, it's someone who can critically navigate digital health information, adapt to recommendations to their realities, and meaningfully engage with digital health systems within the context of their everyday life. So, what's the final takeaway? Because again, all of this came about because we were trying to improve um, sustained behavioral change when it comes to building interventions for health behavior change. So, viewed from the lens of COMBI, which is capability, opportunity, motivation leading to a behavior, um, digital health emerges through an interaction of capability, talking about knowledge and skills, which is psychological and physical capability, and then opportunity, talking more about the context, and then motivation, which talks more about still context, so talking about trust, relevance, that's purpose, confidence to do it, and engagement itself. And so these interactions are then as capability, opportunity, and motivation are shaped by knowledge, skills, and this contextual realities. And all of this is to help us think of the fact that when digital health fails, sometimes the problem is not just about the person, it's that digital systems were never designed to meet people where they are. So now imagine if um, just a minute, I have my toddler saying something here. Give me a second, please.
It's okay. The beauty of live presentations with children in the room. Maybe you can bring her to the webinar. She might be interested in saying something. Meanwhile, I remind participants to put in the chat any questions you might have.
I'm so sorry.
No
And
problem
I'm
at all.
back.
I know the
Thank you.
feeling. Are you
Thank
okay
you. I'm almost
continuing?
done.
Yeah,
Yes, I'm
it's okay.
okay. Yes. And now, so imagine if these domains, knowledge, skill, and context, are embedded in our digital health system, such that when people are presented with digital technologies, they support them, they adapt to their knowledge, their skills, and their context. So, and that would then impact how measurements are developed, interventions are designed, and policy is being made, because now you're adapting to people's um, AI enabled systems are helping to adapt to these core domains of knowledge, skill, and their context. So what next? What are we doing? And that's one of the things we are now trying to do in the next few months is to create practical resources to support stakeholders, that's web developers, clinicians, researchers, in integrating health literacy into intervention design, delivery, and then evaluation, so that um, people don't have to always be the one to adapt to technology. but technology adapts to them. And we are also trying to use all of these domains that we've found to establish a consensus-based definition of e-health literacy. And so the evolution of e-health literacy, what we see now, it does mirror the broader shift in health literacy also, which is from viewing literacy as an individual skill to then understanding it as dynamic interaction between people, system, and context. And so if digital health is shaping the future of healthcare, then e-health literacy will shape who can meaningfully participate in that future. So that's it. Thank you.
Excellent. Thank you. Thank you, Comfort. I will leave now the questions to the floor. If anyone wants to intervene or say any comments, you can put them in the chat if you don't want to speak. Otherwise, people can unmute. And meanwhile, yeah, congratulations. Thank you from Simon. Good to see you. From Julia as well. I see other friendly names in the list. If there are no questions, I can start by asking to reflect a bit on the process you went through, and what do you think consensus was not reached at the end on the item, some of the items, yeah.
Like I said, it wasn't so much about those items not being important, but if we are looking at it critically, they were either items that were already in the core domains. So there was no need to have overlaps of the same idea in different items, or they were not necessarily integral to understanding e-health literacy. So scanning behavior was already in technical skill anyway. Same with information seeking. They were details that if we put it there will be an overlap from the core domains, and we just want to make sure that it's as concise and yet comprehensive enough for the conceptualization of e-health literacy. So it can then inform the way measurements are designed.
All right, what are the next steps if you wanted to summarize? Probably also Simon wants to intervene.
Okay, good to see Simon.
There's a question in the chat here. What about the use of digital health literacy interchangeably with e-health literacy from a research point of view? Well, yeah, good point.
That question always comes.
Yes.
So it's, for the sake of this research, it's the same. Right now, we're looking at everything, and e-health literacy is still being used for us because that was what we started with. And that is a term that's been used over time. But we do embed digital health literacy, telehealth literacy, mobile health literacy into it. So it wasn't just looking at electronic health literacy, but it's everything broadly.
Did you notice
and maybe we'll come to a place where we'll get a consensus on which term we would stick to. But right now, there's no consensus on that.
I have a follow-up question just to remind ourselves from what you did also. Did you notice any disciplinary differences in the definitions from the literature, from the scoping review you did at the beginning?
I do not recall saying that. I think because many of the research was also multidisciplinary. So it wasn't just behavioral sciences, scientists doing the research and that was it. So it was different fields also producing the research. So I didn't see a pattern in the scoping review. I think Simon wants to.
Right, Simon, please come in.
No, I mean, we could probably spend another hour just talking about this question, but everybody, great presentation, Comfort. So just, I mean, on this point, it's a really interesting point. So someone did a timeline of interventions in behavioral science that have been digital, e-health, etc., and the terminology used. And what was really fascinating when they did this, there's this cyclical process. So it starts off like talking about eHealth, then it moved to digital, and then it moved to telehealth, and then it moved through this space where it came back to digital, then back to eHealth. So fascinatingly, I don't think this is just necessarily a disciplinary issue. I think this is actually an evolution over time as people have reconceptualized and re-talked about. And then mHealth was another one that slipped in there as well, right? So I think as Comfort highlighted, this is a really interesting question in terms of what do these terms mean to people and what do they mean to people in a certain space at a certain time? Because that is a forever moving target. And that became really an interesting conversation point in this process. So I don't think there's a solution that I could give, but it's a great phenomenon to explore unto itself.
Probably just to acknowledge for the time being, because otherwise Comfort will spend an entire life doing a PhD, and I don't wish that has to happen, of course. Okay, I think you briefly talked about this. Probably what would be the next step in terms of measuring health literacy? Because we talk about in length about the eHealth, the electronic health literacy scale that was developed 20 years ago now. Maybe is it time to park that instrument or to evolve it? What's your take on this?
It was sufficient for that time.
Yeah, okay, yes.
But for this age and this time that we have. And while I personally don't have the next steps in my PhD research, but the hope is that all of these core domains can then be built into, okay, how do we measure knowledge realistically in real time? How do we measure skills in real time? How do we measure context in real time and bring everything together to then produce the comprehensive measuring tool for eHealth literacy with the hope of it not just be subjective measures, because what we have now is very subjective. People just filling questionnaire or simulating whether they are on the computer, things like that. But having real-time, objective measure of eHealth literacy. So these domains can be like the building blocks that can be used to then build the measuring tool. I think Simon said something a while ago. Those in Europe are trying to do that. So if my work gets published early enough, it can help guide what they're already working on in European public health space. So
yeah, probably public health and behavioral science space. Yes. Catherine, you raise your hand very kindly.
Hi, yes. Wonderful work, Comfort. That was really well presented, and I really loved learning about that. I'm a PhD student at the University of Maryland here in the US, and interested in eHealth literacy as well. And I was just wondering, with your framework, and you offered an example, it seems like some people might have just naturally higher levels of eHealth literacy skills based on their context. And I was wondering what those built-in inequities maybe, what that means for your framework and how you would measure it. If some people just naturally are always going to have these higher levels of eHealth literacy skills than others, just based on specifically those context factors that you guys highlighted.
Yeah, thank you. That's a very interesting question. And I think and I put it in the next steps, which one of my goal is that instead of people having to then adapt to it, digital systems are curated in a way that it adapts to people. So whether you have low or high eHealth literacy, or there's context predisposes you to have tendencies for high eHealth literacy level, the system itself adapts to fit into the person's level, which will then help empower that individual in their health decision-making process. So it's not like one person is left behind. Those who are predisposed towards low eHealth literacy are then left behind, and they're making some funny I'm predisposed to misinformation and disinformation, but like systems just adapt based on eHealth literacy level being measured as you interact with them. That's the ultimate goal in my heart, is the fit with the system demands.
Thank you. Yeah, so maybe that might be like some like automatic processes in healthcare where it's kind of tracking that sort of
Yeah, things like that.
behaviors. Okay, thank you.
Excellent. Thank you, Catherine. Catherine, any other questions? Yeah, bring her if you want. Comfort.
It's music we are fighting, and I want this song. I don't want that song.
That's fine. I have another question for you if you want. So, can you tell us in a sentence, let's say, what is the essential nature of the eHealth literacy 2.0 or 3.0 for now?
I didn't get that. Can you repeat that?
So if you wanted to summarize whatever you've done in a sentence, I know it's a very hard question, what would that be? So what are the essential elements of eHealth literacy in 2026?
I would say that bringing in eHealth literacy in 2026, in this digital age, should be conceptualized as individuals' knowledge, again, the domains, their skills, and within the context of their daily life, basically, if I want to summarize it. But I did use the statement I made. I'm trying to see if I have it in the slide. Yes, which is that an eHealth literacy should be conceptualized as an interaction between the user's capability and the digital system's demands. So whatever system it is, whether it is mobile, digital, electronic, in Web 2.0, Web 3.0, or between the users, this is based on the result that we have here. The eHealth literacy should be conceptualized as interaction between users' capability and the digital system demands, basically. So, and that's what captures the context part. So users' capability captures the knowledge and skills, and the system demand captures the context.
Right, excellent. Thank you. Thank you so much. If there are no more questions from the floor, the virtual floor, I think I can just thank you once again. Oh, hello. Thank you again. And so Amy put in the chat the new series. I mean, there are 3 more webinars to the end of this academic year, call it season. For those who are interested, can link there. Otherwise, I'll catch up next time. In June, we have a new interesting webinar on information voids with Dr. Santosh Vijay Kumar from the University, Teesside University, if I'm not mistaken. Right. Thank you so much for attending, and I'll see you next time.